So MERMAID-2 is a very exciting study. This is taking advantage of emerging technology to try to find other ways to assess how patients might be at high risk for cancer progressing or returning, in this case of early stage lung cancer. The study is really quite simple. It's looking at patients who have stage 2 or 3 resected, definitively resected non-small cell lung cancer, and then having those patients receive standard adjuvant platinum-based doublet chemotherapy according to histology. The study is really designed to look at those patients after they've completed adjuvant therapy and then assess the presence or absence of what we're terming minimal residual disease using a plasma-based assay looking for circulating tumor DNA. And so the study works like this. You have surgery, you're resected, hopefully for cure. You then receive adjuvant therapy in a very standard manner. And then you are assessed for circulating tumor DNA using a plasma-based assay. For those patients who have presence of disease, what we're terming MRD, minimal residual disease positive, those patients are then examined more closely to see if you can identify that disease in recurrence. And if you identify it through scans, then they're really not a part of the study. In fact, they come off the study. But the patients who are MRD negative, and by scans you can't find it, it's only MRD presence in the blood, those patients are then randomized to immunotherapy, in this case durvalumab, given monthly for 2 years, or to a placebo. And so the study is just trying to identify those patients by the presence of circulating tumor DNA who we would think would be at high risk for early recurrence and ultimately poor survival, and intervening with in this case with immunotherapy. Remember, they've already received chemotherapy or not, and to see if that leads to an overall advantage in terms of disease-free survival, the primary endpoint of the study, among several other endpoints, secondary endpoints, including overall survival. Patients will be followed, those that are MRD negative will be followed for about 2 years to see at regular intervals with blood-based assessments to see if a clone emerges. And then at that point, of course, they would be randomized to durvalumab or placebo. So I think really a very exciting, scientifically exciting study, an opportunity to do more than just give everybody platinum-based doublet chemotherapy. Unfortunately, we know despite the advantage for survival for that therapy, we still have a large number of patients who still end up recurring and ultimately dying from lung cancer. Could immunotherapy change that outcome for those patients at high risk or who are showing disease presence in the form of MRD positivity? That's an important question to answer. So we're very excited to be a part of this global study. The study has launched already, and hopefully you have access to it at your center. And if not, look for this. It's probably at a center near you. So we're excited to get this up and running and hopefully get an answer here in the next several years. So this study, again, is looking at patients with both squamous and non-squamous histologies who undergo definitive RO resections and have stage 2 and 3 lung cancer. This does not include patients with known EGFR or ALK driven lung cancers. Particularly for EGFR these days, we recognize the role of osimertinib in the adjuvant setting in early stage disease, certainly in some places in the world. And this is not a study for patients with mixed histologies, say small cell, non-small cell. The usual kind of criteria that we would expect that would exclude patients from immunotherapy are in this study as well, because obviously the intervention here is PD-L1 inhibitor durvalumab. But that's a drug many are very familiar with for stage 3 non-small cell lung cancer treatment, and I think are very comfortable with identifying those patients that might be at higher risk and therefore not eligible for this study. So really a wide open study in terms of the criteria to get on. I think they're relatively limited. Obviously, we want the best in surgery for our patients. We want all our patients to get access to platinum-based doublets, and there are options there based on histology and preference for regions of the world. That was something that was vetted with a global steering committee. And again, the intervention, I think, is pretty straightforward. It has a placebo design that's important to know. Trying to think of other things we didn't mention. I guess maybe one caveat, this is a subtle point, but at any point, if a patient converts from MRD negative to MRD positive, they would be eligible, but not if you could find disease by imaging. So just think through that for a moment with me. If imaging could find cancer, that doesn't really offer an advantage. Sorry, this study doesn't offer an advantage over standard practice, because our patients, say with stage 2 disease who are treated today, we follow them periodically with imaging, and if we found cancer on imaging, we would intervene. This study is trying to take advantage of disease that you cannot see on imaging, that is so-called occult, but that you could pick up in the blood. So that's an important point. So a patient is followed, they become positive in the blood, they go through imaging to see if we can identify the source of that positivity. If you identify it by imaging, they're off the study, so they're not randomized to immuno or not. It's only for those patients who are so-called image negative MRD positive that convert to that. So, but an exciting study, and I think I mentioned DFS, disease-free survival, is the primary endpoint, but clearly all the traditional secondary endpoints, including overall survival and a lot of ancillary or correlative secondary endpoints, I think that we hopefully can learn a lot about. Well, this study, was just opened globally, and it's still opening at sites around the world. So there are no findings to share. However, I will maybe brag a little bit on the work of one of the study's leaders, the chair, co-chair of the study, Dr. Charlie Swanton. Charlie's group and others have been spending a lot of time examining the value of MRD assays to prognosticate patients' risk for recurrence. And so we know from some of those, we know from modeling, and we know from some of that work out of Dr. Swanton's group, that those patients who have MRD positivity after definitive resection are kind of a poorer risk group of patients who have a higher risk of recurrence later by imaging and classic measures. And so that really has been the impetus for designing this global effort.